Hello and welcome in this final video on how to read a brain CT. In the first two videos we talked about the basic principles of CT, how a CT image is generated, what are the basics of CT interpretation. In the second video I talked about brain anatomy on CT, and now finally we can talk about brain pathology. Of course, I'm not going to talk about every pathological entity out there, but the most common ones or the most frequently asked ones from your referring physicians. Needless to say, CT is often the first examination performed in trauma patients or in patients with acute neurological symptoms, so the emphasis will be on that kind of pathology. Well, when you do a search for pathology on your CT, you can start with a very quick check. So before trying to discover subtleties, I do a quick check, namely, is the midline normal? Is there a normal position of the midline? Because if there isn't, that already indicates the presence of a space-occupying process somewhere. Is there a normal differentiation between gray and white matter? I told you that the densities of gray matter and white matter are different, and they should be different. If you can no longer distinguish or make the difference between gray and white matter, you're probably or possibly dealing with subtle edema and a sign of early ischemic infarction or an early sign of ischemic infarction. Look at the size of the ventricles to rule out hydrocephalus, or if they are narrowed, to rule out a space occupying process narrowing the ventricles. Also look at the basal ganglia. For the same reason, you should check the gray-white matter differentiation. The basal ganglia are gray matter structures, so you should clearly see the difference between these gray matter structures and the surrounding white matter of, for instance, the internal capsule. If you don't, you are possibly dealing with edema and possibly with ischemic infarction. And lastly, look at the basal cisterns. These should be open. If they are compressed or effaced, you are also possibly dealing with a space-occupying lesion causing transtentorial brain herniation. Okay, these are just some quick rules to immediately look for something urgent. Now let's talk about several entities in a bit more detail. Keep in mind this is going to be a short presentation, so it just covers the basics. It's just to get you started. I'm going to talk about acute ischemic stroke, brain hemorrhage, hydrocephalus, and brain herniation. We're going to start with acute ischemic stroke. What is a stroke? Well, basically, rapidly developing clinical signs of a focal or global disturbance of cerebral function lasting more than 24 hours or leading to death, with most likely with no apparent cause other than of vascular origin. Okay, that's quite a mouthful. This is the definition by the WHO that is still widely used nowadays. What does this mean? In easy terms, well, basically it means an ischemic stroke is caused by an obstruction of blood flow to a certain part of the brain, causing that part of the brain to become necrotic, to die. And as you can see on this image, this is an established infarction. We see that the brain becomes edematous and swollen, making it become very dark on a CT image. It is important to know your arterial territories to recognize an ischemic infarction on a CT image, because if an artery is occluded, only the part of the brain that is supplied by that specific artery will infarct, and only in that part of the brain will you see signs of ischemic infarction. What are the main arterial territories of the supratentorial brain? We have the territory of the middle cerebral artery, which is the biggest territory, composing most of the lateral part of the cerebral hemisphere. And if you have a stroke in the middle cerebral artery territory, patients will present with a contralateral hemiparesis affecting the arm more than the leg. And if the stroke is located in the left hemisphere, patients will generally present with aphasia. If the anterior cerebral artery territory is located anteriorly along the medial surface of the cerebral hemisphere, and a stroke in that territory can lead to a contralateral hemiparesis with the leg more involved than the arm. Lastly, the posterior cerebral artery territory is located at the back and the medial surface of the cerebral hemisphere. This contains the primary visual cortex, so patients, when having a stroke in that area, will present with contralateral hemianopia. Now that we know the vascular territories, it is easy to see an established infarction in those respective territories. Established meaning that the infarction is already at least a couple of hours, maybe even a couple of days old. And in an infarction of that age, the infarcted area will become very swollen and very hypodense. You're basically looking at tissue that is infarcted, it is dead, and it has turned the entire brain area into an area of brain edema. Here we see a patient with a large established infarction in the territory of the left middle cerebral artery. This is a patient with an established infarction in the territory of the left anterior cerebral artery. And lastly, a patient with an infarction in the posterior cerebral artery territory on the left side. Now, the thing is, if a patient has an established infarction, there is nothing that can be done anymore. The goal of imaging is to basically detect patients at an early stage, so when they are still eligible for therapy. And in that stage, the signs of infarction can still be subtle. This is a patient with a large left middle cerebral artery territory infarction, but at a first glance, you really have to look carefully at these images. The midline seems okay, but there's an asymmetry between the lateral ventricles. Mind you, a slight asymmetry can occur in the general population, but it can also be a sign of a space-occupying lesion. In this case, it's not a tumor, it's not a hemorrhage, no, it's brain edema. And although the edema is not as conspicuous as on the previous cases, look carefully. Look if you can see the gray-white matter differentiation in the left cerebral hemisphere. You can't. The gray-white matter differentiation is gone. This is cerebral edema in the territory of the left middle cerebral artery, and this was an early total media infarction. In some cases, the infarction can be located in the territory of a smaller, more peripheral artery. In that case, self-evidently, not the entire territory of the middle cerebral artery or one of the other main arteries of the brain will be involved, but only part of the brain. Here we see a hypodense region located in the left frontal lobe with absent gray-white matter differentiation. This was an early partial media infarction due to occlusion of a branch of the left middle cerebral artery. When looking for signs of infarction, it's important to look for loss of gray-white matter differentiation. Because there is edema, there can be sulcal effacement, and the abnormalities or the region of edema will be hypodense, although this can be very discrete in an early phase. We talked about the stroke window in an earlier video. We'll definitely use it to look for subtle edema in an early infarction. Here's another patient. Does this patient have signs of infarction? At a first glance, we might say, looks okay, but let's window this a bit. Let's use a stroke window. Now, these images are hard to look at, they almost hurt the eyes, but if we now look carefully at the region of the left basal ganglia, what do we see? The lentiform nucleus, clearly seen on the right side, is missing on the left. And there is no differentiation between the cortex of the left insula and the underlying white matter. So these are definitely signs of early infarction, or early signs of infarction rather. And if we now look back at the brain window, yeah, we could have seen it there as well, but it's easier if you use a strong stroke window. The disappearing of the basal ganglia is called the disappearing basal ganglia sign, and you should definitely always check your basal ganglia in a patient suspected of having an ischemic stroke, especially if the patient has symptoms that would fit a middle cerebral artery infarction. And I already mentioned it, also look at your insular cortex. Let's examine these images. Let's magnify them a bit. What do we see? The left lentiform nucleus is missing again, at least partially. We can clearly see it on the right side. On the left side, maybe here there's something left, but the rest is dark. But what is missing as well? The cortex of the left insular ribbon, or the left insular cortex rather. Clearly seen on the right side, absent on the left. This is an insular ribbon sign or absent insular ribbon, and is also a sign of early infarction. A last sign you should look for is a dense artery sign. Sometimes the thrombus can be visualized on unenhanced CT images, and a thrombus consisting of clotted blood will be very bright or hyperdense. However, be careful. It's nice if you see a dense artery sign, but you will still have to do a CT angiography and keep in mind that there are many false negatives. There are many false negatives because you only have a hyperdense artery sign in 30% of cases, and you can also have false positives. For instance, if a patient has ateromatosis of the main branch of the cerebral artery, for instance. So this sign does not obviate you from the need to do a CT angiography. Let's move on to brain hemorrhage. I told you these would be very short presentations. An acute hemorrhage is hyperdense. The word acute is very important here because as a hematoma ages, it will gradually liquefy and be resorbed by the body, and it will gradually become more hypodense. So in this presentation, I'm talking about acute hemorrhages in the brain, and they will all be hyperdense on the CT images I am showing you. When seeing a brain hemorrhage, so if you see a hyperdense abnormality, chances are it's a hemorrhage. What is important in a hemorrhage? That you localize it accurately. You localize it as being either inside of the brain or outside of the brain. And if it's outside of the brain, you have to try to determine in which meningeal compartment it is located. Is it a hematoma in the epidural space, an epidural hematoma, a subdural hematoma, subarachnoid hemorrhage, maybe a ventricular hemorrhage? And when it comes to the deep hemorrhages located inside the brain parenchyma, you can also make a distinction which will have implications for the differential diagnosis between a parenchymal hematoma located in deep structures and a parenchymal hematoma located superficially in the brain, a so-called lobar intraparenchymal hematoma. Let's examine these various hematomas or hemorrhages one at a time. Let's start with an epidural hematoma. An epidural hematoma is a blood collection located between the skull and the dura. I drew the dura for you, and you can see that this hematoma is located between skull and dura. Of course, in a normal situation, you cannot recognize the dura on a CT. So how can you tell this is going to be an epidural hematoma? Well, basically, mainly based on the shape of the hematoma. So what can a epidural hematoma never do? It cannot cross the sutures. Why is that? The hematoma is located between the skull and the dura, but the dura is very firmly attached to the skull at the level of the sutures. It is so firmly attached that a hemorrhage cannot pass it, unless a fracture line were to pass through the suture. In that case, it can. So, because it cannot cross the sutures, it cannot expand any further along the brain surface and will expand how am I going to say this? It will expand in this direction. Look at my arrow, I can't find the word, giving the hematoma a typical lens shape or a convex shape. And this is very characteristic. What is also very typical for the epidural hematoma, they are almost always traumatic, and in the majority of cases, more than 90%, you will find a skull fracture in the overlying skull. And the hematoma is caused by a laceration of an artery running along the inner surface of the skull. So, how can I tell this is an epidural hematoma? Because it has a very typical convex shape, a typical lens shape. It seems to stop at the level of the coronal suture and the lambdoid suture, and an epidural hematoma cannot cross the sutures. And let's just pretend that I have also a bony window, which clearly shows a fracture line here. Well, these are all signs of epidural hematoma. A subdural hematoma can look a bit similar, but not quite. In most cases, you can clearly tell the difference. A subdural hematoma is located between the dura and the arachnoid, so it's located underneath the dura. And it can cross the sutures, but it cannot cross the midline, which makes sense because the dura will fold inwards along the midline. And because the hematoma is located underneath the dura, it can never cross the midline, self-evidently. So the arachnoid we cannot see, but just imagine this is the arachnoid over here. Because the hematoma can spread along the entire cerebral hemisphere and even further along the falx, for instance, it will never adopt the typical lens shape we have seen in an epidural hematoma and will be more crescent-shaped, often with a concave inwards border. These hematomas are mostly traumatic, but especially in elder patients, the trauma can be very minor, and in a lot of cases, patients cannot remember they had an accident. Well, I'm talking about older patients, that is. A subarachnoid hemorrhage is a hemorrhage located in the subarachnoid space. And the subarachnoid space, of course, well, the sulci or subarachnoid space, so it is clear that blood in the subarachnoid space will follow the contours of the sulci and or the basal cisterns. Subarachnoid hemorrhages are seen in a lot of traumatic brain injuries, so they can be traumatic. They can also be spontaneous, and if you're dealing with a spontaneous, a non-traumatic subarachnoid hemorrhage, your main worry should be if the patient has a cerebral aneurysm and CT angiography should be performed. Can you tell the difference, or can you predict if a hemorrhage is going to be traumatic or caused by an aneurysm? Nothing is 100%, but in a traumatic subarachnoid hemorrhage, most cerebral aneurysms are located at the base of the brain, so that is where you will find most subarachnoid blood. Subarachnoid An aneurysmal subarachnoid hemorrhage will mainly, the subarachnoid blood will mainly be located in the basal cisterns and less along the cerebral hemispheres. This is a typical pattern as can be seen in a ruptured cerebral aneurysm. In a traumatic subarachnoid hemorrhage, the blood can basically be located anywhere, but the predominance of blood in the basal cisterns will often not be present. In this patient, the blood was mainly located along the right cerebral hemisphere, but there was no blood in the basal cisterns, which is very unlikely for a ruptured aneurysm. Furthermore, the patient also had a subdural hematoma along the left side, making this a pretty easy case. This was a traumatic subarachnoid hemorrhage and also subdural hematoma. Let's move on to hemorrhages or hematomas located inside the brain parenchyma. So these can be traumatic and spontaneous. When intraparenchymal hematomas are traumatic, they often have a predilection for the cortex of certain brain areas along the base of the brain. Spontaneous hemorrhages tend to often be either deep inside the brain parenchyma, but can also be superficial. And in that case, we call them lobar intracerebral hemorrhages. And as said, brain contusions are seen after trauma. This is what brain contusions typically look like. We see these very small patchy hemorrhages, somewhat surrounded by edema, located at the base of the frontal lobes and also anteriorly in the temporal lobes on both sides. There is associated subarachnoid blood, some subdural blood. I admit it is not so easy on these images, so just believe me. And this is basically some kind of traumatic brain bruise. This occurs following an acceleration-deceleration injury of the head, causing the brain to slide over the bony ridges of the anterior cranial fossa and against the middle cranial fossa. The locations are quite typical, although basically contusions can occur anywhere, but these are definitely predilection sites. They are often patchy, you often have multiple, often surrounded by edema, and there is often local subarachnoid hemorrhage present. These are two patients with spontaneous intraparenchymal hemorrhages. In elder patients, if you have a spontaneous intracerebral hemorrhage located deep within the brain, in the region of the basal ganglia for instance, it is very likely going to be a hypertensive hemorrhage. Also notice that this hemorrhage has ruptured into the ventricular system. If you have an intraparenchymal hemorrhage located superficially in the brain, a so-called lobar intracerebral hemorrhage, in an elderly patient, it is very likely that it is going to be secondary to so-called cerebral amyloid angiopathy, which is a disease causing weakening of especially leptomeningeal and cortical arteries due to the deposition of a certain protein, amyloid proteins, in the vessel wall. Primary hypertensive hemorrhages are, as said, mostly found in deep brain structures, and predilection sites are the basal ganglia, the thalamus, the brainstem, and also the cerebellum. If you see a spontaneous intracerebral hemorrhage in an elderly patient, chances are the patient has chronic hypertension, and this is a primary hypertensive hemorrhage. Let's summarize hemorrhages. I've shown you the several kinds of hematomas you can encounter on CT imaging based on their location. We have seen epidural hematomas, which have a typical lens shape and cannot cross sutures. We have seen subdural hematomas. Oh yeah, they have a convex inner border. We have seen subdural hematomas, which are crescent shaped, follow the dural contour or the surface of the cerebral hemisphere. They cannot cross the midline, however, and subarachnoid hemorrhages, which are located inside the sulci and follow the sulcal anatomy. We have also seen intraparenchymal hematomas, brain contusions, often very patchy and located at typical locations such as the base of the frontal lobe and the temporal pulse. And we have seen deep intracerebral hemorrhages, which are often hypertensive in elderly patients, and lobar intracerebral hemorrhages, which are often secondary to cerebral amyloid angiopathy in elderly patients. The cause can be traumatic or spontaneous, but epidural hematomas are almost always traumatic, as are most subdural hematomas. Subarachnoid hemorrhage can be both, but we have seen the difference between the pattern of an aneurysmal subarachnoid hemorrhage and a traumatic subarachnoid hemorrhage. Ventricular hemorrhages can be traumatic or spontaneous, and we have contusions. When it comes to spontaneous hematomas, we have the subarachnoid hemorrhage due to a ruptured cerebral aneurysm, and we have our parenchymal hematomas, either deep or lobar. Let's talk now about brain herniation. What is brain herniation? Well, the brain is, or the skull rather, is a closed box, holding the brain, surrounded by cerebral spinal fluid and vascular structures. It has a fixed pressure, so as soon as you have a space-occupying lesion causing an increased intracranial pressure, you will get a shift from brain structures from their normal location, and that is called brain herniation. There are several types of brain herniation, but I'm only going to show you two of them, but they are the two most important and frequent ones. You can have herniation of brain tissue underneath the falx, and this is called subfalcine herniation. This here is an epidural hematoma causing a shift of the brain parenchyma to the other side, and it presses the ipsilateral brain parenchyma underneath the falx to the underside. Then we have another structure, the tentorium cerebelli. I have told you about the tentorial notch, the opening anteriorly of the tentorium for the midbrain. If you have a space-occupying lesion supratentorially, this can cause herniation of brain tissue through the tentorial notch, and this, if it is unilateral, is called uncal herniation. But if the herniation occurs bilaterally or from central in the brain, it's called transtentorial herniation. Now, the most important thing for us as radiologists is be able to recognize them. Here I'm showing you two patients with deep intraparenchymal hematomas. And what do we see? We see a clear shift of the midline, which is a sign of subfalcine herniation. Let's draw a line. We can suspect where the falx cerebri would insert, both anteriorly and posteriorly. Let's draw a line along that virtual line in this case, and let's see where the midline structures of the brain, like the septum pellucidum, are now located. These are clearly deviated towards the other side. So we have a space-occupying intraparenchymal hematoma located in the right cerebral hemisphere, causing a subfalcine herniation to the left. This is a very important thing to notice as a radiologist, to report or to even, well, not just write it down in your report, call your neurosurgeon or your emergency physician right away, because this is extremely important. How do you measure a midline shift? There are several ways you can do it. The easiest one for me is draw a line along the course of the falx, or where the falx should normally be located. Locate a certain midline structure, often the septum pellucidum, and see if there is any deviation. In this case, there isn't. In this case, quite obviously, there's a deviation to the right side. So that's how I measure it, but in the literature you'll find other methods. Another kind of herniation, well, not right away. What do we see in this patient? Clearly something is going on in the right cerebral hemisphere. We have here a large space-occupying lesion, and this was a glioblastoma, a very malignant tumor of the brain. It is surrounded by hypodense brain edema, and notice how the cortex is not involved. The cortex is not involved by the edema. This is a sign that we are not dealing with an ischemic infarction, because in an ischemic infarction, we would have loss of the gray-white matter differentiation. But that's not so important right now. We are going to talk about herniation. What do we see? Let's draw a line along the presumed course of the falx cerebri, and we see that the septum pellucidum is located here. Also notice the narrowing of the right lateral ventricle, and there's a clear shift of the midline to the left side. This is a left-sided subfalcine herniation, or a subfalcine herniation to the left, rather. Let's take a look at another slice in the same patient. Here is the tumor surrounded by edema. What is this? This is the mesencephalon, or the midbrain. But the morphology is not normal. Why is that? Because it is compressed. And do you know what this is? This is the uncus of the temporal lobe. This is an uncal herniation causing compression. So the right mesiotemporal brain structures are herniating through the tentorial notch, causing compression of the midbrain. This causes narrowing and effacement of the basal cisterns, flattening of the mesencephalon, and a deformation of the normal morphology of the mesencephalon. Let's look at it in the sagittal plane. If we look at the sagittal plane, or let's look in the coronal plane, we can clearly see the tumor located over here. This is edema, and we see here the tentorium. I'm going to remove these. Yes, can you see it? These very faint, dense lines. And we see that the brain parenchyma is herniating over the tentorium on the right side. In the mid-sagittal plane, we would normally expect to see third ventricle over here. Instead, we see part of the tumor causing compression of the surface of the midbrain. Let's talk about hydrocephalus, and this is the final topic of today. What is hydrocephalus? It's an increased amount of cerebrospinal fluid in the ventricles, causing or associated with increased intracranial pressure. It can be communicating or non-communicating, and the main differential diagnosis, especially in the elderly population, would be with enlarged ventricles secondary to cerebral atrophy. But the difference is actually not that difficult. Let's compare these two patients. Which patient has hydrocephalus? I think anyone will agree that it is the patient on the left side. We see clear widening of the ventricles, but let's look at the sulci. These are completely effaced. This is because there is increased intracranial pressure due to the hydrocephalus, causing effacement or compression of the cerebral sulci. In patient number 2, however, we see widening of the ventricles, but we see a lot of atrophy and also tissue loss generalized, because this was a patient who suffered a severe hypoxic ischemic encephalopathy, causing generalized cerebral damage and cerebral atrophy. Notice that the ventricles are widened, but the sulci are very open and not narrowed at all. So this is what we could call an ex vacuo, or a passive ventriculomegaly secondary to tissue loss or atrophy. When it comes to hydrocephalus, the ventricular size is disproportionate compared with the sulcal width on CT images. So if you have large ventricles and the sulci are completely effaced, you should definitely consider hydrocephalus. And then the next question is, what is causing the hydrocephalus? To answer that, try to determine if it's a communicating or non-communicating hydrocephalus. Let's take a look here. We clearly have widening of the lateral ventricles, clearly seen also on the sagittal plane, as well as widening of the third ventricle. I have told you that if you're dealing with a hydrocephalus, look at the outlets or the narrow passageways. Now, the foramen of Monro cannot be involved because we have both widening of the lateral ventricles of the third ventricle. Let's look at the cerebral aqueduct. Can't be seen. Why not? Well, first of all, because there is compression of the cerebral aqueduct, no communication is possible between the third ventricle and the fourth ventricle, so we are dealing with a non-communicating hydrocephalus. And the hydrocephalus is caused by a large pineal gland tumor compressing the cerebral aqueduct. Here's another example of a patient with a hydrocephalus. We see clear widening of the ventricles, massive widening with complete effacement of the cerebral sulci, but also notice that there are periventricular hypodense white matter changes. This reflects edema. Water is basically compressed from the ventricles into the brain parenchyma due to the increased pressure in the ventricular system. And that is what that would look like on a FLAIR image. This is the same patient, and this is transependymal edema. Water being pressed from the ventricles into the periventricular white matter. And can you see the cause? We clearly see massive widening of the temporal horns of the lateral ventricles and the third ventricle. Is this fourth ventricle? No. This is fourth ventricle, and this is a tumor compressing the fourth ventricle. This was a tumor in a child. I cannot remember which one it was, if it was a medulloblastoma or something else, but whatever the cause, this patient had a non-communicating hydrocephalus due to an obstruction at the level of the fourth ventricle by a tumor. This is a 32-year-old female patient. Does she have hydrocephalus? The ventricles look a bit widened, one must say, and the sulci cannot clearly be discerned. It is a young patient. In young patients, it's normal to not see much sulcal widening, but still, if you are in doubt, there's one thing you should look at. Look at the temporal horns. The temporal horns are the most sensitive to early changes or to widening in hydrocephalus. They are often the first component of the lateral ventricles to dilatate if a patient develops a hydrocephalus. So always check your temporal horns. In young people, these should be very flimsy. If they look swollen like this, something is clearly off, and this is a hydrocephalus. And what is the cause? Well, lateral ventricles, third ventricle, basically septum pellucidum, but never mind, third ventricle, fourth ventricle, cerebral aqueduct looks open. This is a communicating hydrocephalus because all ventricles can communicate with one another. The foramen of Magendie looks open. So where's the compression? Let's look at the MRI image. So this is a communicating hydrocephalus due to a tuberculous meningitis. Do you see this structure located in front of the brainstem? This was a basal meningitis due to tuberculosis. Okay, we're almost through. Then there are some other pathological entities I think are important to know as a radiologist. This is a patient in status epilepticus, had fever, and what do we see? Well, we see a lot of artifacts, making this very difficult, but nevertheless, the right temporal lobe is very bothersome. And if you see temporal lobe edema in a patient that is acutely ill with seizures, fever, and so on, definitely consider herpes simplex encephalitis, which was the case in this patient. So temporal lobe edema in an acutely ill patient, always, always, always consider herpes simplex encephalitis. Here's another example of a young woman who was brought to the ER because of status epilepticus, and we clearly see edema involving the left temporal lobe, both on the axial image and on this coronal image. This was also herpes encephalitis, and here it is more subtle, but look very closely. 64-year-old man found at home, drowsy. We see that the right mesotemporal region is very hypodense, both in the axial images as on the coronal images. Compare the right hippocampus with the left one, it's clearly swollen and hypodense. This was another example of herpes encephalitis. This is a patient with diffuse brain edema, a 4-year-old boy who was found and suffered an incident, but I cannot really remember what it was, but whatever it was, it caused massive brain edema. This was a hypoxic ischemic encephalopathy. We see that the brain parenchyma is diffusely hypodense. There is complete sulcal effacement. The lateral ventricles are completely narrowed and there is no gray-white matter differentiation whatsoever. The only thing we see is that the cerebellum is spared and looks relatively bright compared to the swollen brain parenchyma above it. And this is called the bright cerebellum sign, but is definitely not always present, and the cerebellum can also be involved. So this is what diffuse brain edema looks like, as can be seen following a severe hypoxic ischemic incident, for instance, a drowning, a cardiac arrest, strangulation, or something else. Last case, this is a woman who developed seizures shortly after giving birth. And what do we see? Oops. We see hypodense changes in both occipital lobes. The cortex is spared. They are located in the subcortical white matter. You could say, could these be bioccipital infarctions? But then it is strange that the cortex is not involved. This was PRESS. PRESS, posterior reversible encephalopathy syndrome. It's a syndrome characterized by often occipital or parieto-occipital edema mainly located in the watershed areas of the brain, and which can be seen in association with a variety of clinical situations such as malignant hypertension, acute kidney failure, certain medications such as chemotherapy, and also following delivery or in cases of eclampsia or pre-eclampsia. So if you see a bioccipital edema and it's not an ischemic infarction, think PRESS, especially if there's a clinical situation that would fit that diagnosis. Okay, this was a long presentation. Always difficult to find good key messages if the presentation was long, but I'm going to try. What do I think is very important? Well, that you know brain anatomy and so on goes without speaking, but that you are aware of your artifacts. Know your artifacts, recognize motion artifacts, beam hardening artifacts, and partial volume artifacts so that you avoid mistaking them for pathology. The second one is use windows, because you can just look at your brain window, but if you do that, you will miss skull fractures. So look at the bone window for that. And you can miss signs of early infarction or early signs of infarction. If you don't use a stroke window, you can miss a subtle subdural hematoma if you don't use a subdural window. So learn how to window, know how to window, and window the shizzle out of your images. The last message, or the forelast message, know what to look for when dealing with a patient suspected of having an acute ischemic stroke. Know your signs or early signs of stroke, like the disappearing basal ganglia sign or the disappearing insular ribbon sign. And last message, never miss one of these: hemorrhages and localize them correctly, hydrocephalus, brain herniation, and when dealing with temporal lobe edema, herpes encephalitis. 4 H's you shouldn't miss: hemorrhage, hydrocephalus, herniation, and herpes encephalitis. So that concludes this lecture on how to read a brain CT. Thank you very much for watching. If you have any questions, comments, or feedback, leave a message at the comment section or send me an email. Thank you very much for watching.